Today I'm going to be teaching you about the needle chest decompression to help alleviate a tension pneumothorax in a casualty. Suspect a tension pneumothorax and treat when a casualty has significant torso trauma or primary blast injury and one or more of the following: severe or progressive respiratory distress, severe or progressive tachypnea, absent or markedly decreased breath sounds on one side of the chest, hemoglobin oxygen saturation less than 90% on pulse oximetry, shock, or traumatic cardiac arrest without obviously fatal wounds. The needle chest decompression is performed using a 14 or 10 gauge 3 1/4 inch needle catheter. There are two acceptable sites for the needle chest decompression: the 5th intercostal space on the anterior axillary line or the 2nd intercostal space at the midclavicular line. The nipple level is variable in females, but you can lift the breast and use the level of the inframammary fold. I'm going to demonstrate on the 2nd intercostal space, midclavicular line. I want to locate my patient's clavicle, which is also right above the first rib. Underneath that is the 1st intercostal space. Moving down, I find the patient's 2nd rib. Underneath that is the 2nd intercostal space. I'm going to insert my needle catheter here, directly above the 3rd rib, so that I don't hit any arteries or veins along the bottom of that 2nd rib. If the anterior MCL site is used, it is critical to remain lateral of the nipple line to avoid the heart and large blood vessels. Once I've identified my site, I'm going to remove the needle catheter. Remember, it's 14 or 10 gauge, 3 1/4 inch. I have my site identified, and I'm just going to insert this at a 90-degree angle perpendicular to the patient's chest. Insert the needle and catheter fully to the catheter hub and leave in place for 5 to 10 seconds to allow complete decompression to occur. After the decompression has been performed, remove the needle, leaving the catheter in place. The lateral site is located in the 5th intercostal space, anterior axillary line. To locate it, you're going to follow the patient's anterior axillary line to just lateral and below the nipple. Once you've identified the site, take your 10 or 14 gauge 3 1/4 inch needle catheter and begin your insertion. Following the anterior axillary line, I'm going to insert my needle just over the top of the lower rib at the insertion site. Insert the needle catheter unit all the way to the hub and hold it in place for 5 to 10 seconds to allow decompression to occur. After the NDC has been performed, then remove the needle, leaving the catheter in place. The NDC should be considered successful if respiratory distress improves or there is an obvious hissing sound as air escapes from the chest when NDC is performed. This may be difficult to appreciate in high noise environments, or hemoglobin oxygen saturation increases to 90% or greater. Note that this may take several minutes and may not happen at altitude, or a casualty with no vital signs has returned to consciousness and/or radial pulse. If the initial NDC fails to improve the casualty's signs or symptoms from the suspected tension pneumothorax, perform a 2nd NDC on the same side of the chest at whichever of the 2 recommended sites was not previously used. Use a new needle catheter unit for the 2nd attempt. Consider, based on the mechanism of injury and physical findings, whether decompression of the opposite side of the chest may be needed. If the initial NDC was successful but symptoms later recur, perform another NDC at the same site that was used previously. Use a new needle catheter unit for the repeat NDC. If the 2nd NDC is also not successful, continue on to the circulation section of the Tactical Combat Casualty Care TCCC guidelines. Continue to reassess for redevelopment of a tension pneumothorax, monitor SpO2, and document all care on the DD Form 1380.